Okay, welcome everybody to another Community Pharmacy Thames Valley webinar. It's one of many that we've put on over the last year or so. Just to make it clear that I am recording this because we'd like to add it to our YouTube library. So for anyone that needs to go back and look at some of the training that we've done, it's there obviously to use. But welcome everybody. Hopefully you get a lot out of this evening. But I'd like to introduce Claire Holland, who's going to run the webinar this evening. So over to you, Claire.
Great, thank you, David. Thank you all for coming this afternoon, or this evening rather. Our focus this evening is on the new medicine service, particularly with the recent expansion to include antidepressants for the long-term condition depression. So by the end of the webinar, we hope that you will feel confident in delivering your NMS consultations for patients who are starting antidepressants, with some practical tools, highlighting a bit of safeguarding awareness that we need to do, and looking at some communication strategies. But before we begin, and as David said, I wanted to acknowledge that today's topic, depression and antidepressants, can be sensitive and sometimes triggering. You are completely in control of how you engage with the material. So as David said, microphones are already muted, but if at any point you prefer to switch your camera off, take a short break, or revisit the webinar, please do so. Part of discussing mental health is recognizing that we may all have our own mental health challenges or concerns or worries, and looking after our own well-being is just as important as supporting our patients. So if you do feel affected by the content, please reach out to family, friends, trusted colleagues, and use professional support. And use services like talking therapies, mind, and rethink mental illness, which are all excellent resources, and we'll look at them in a little bit later. When we create a safe and supportive environment for ourselves, we model that same care and compassion that we want to extend to our patients. So it's really important that we keep that at the forefront of our minds. And I've just popped some of the wellbeing apps that are available for NHS professionals here as well. Okay, so to begin, before we look at what the new medicine service has in store for us to date, I thought it would be good to look back at its history. So when the new medicine service was launched in 2011, it was fair to say it was in the shadow of the Medicines Use Review, which had already been running for several years. MURs were well known to patients and pharmacists, and dare I say, many area managers. It focused on reviewing medicines that patients were already taking. So identifying adherence issues for medicines that were already in use or safety issues in established treatment. But by contrast, NMS was a more targeted service. It was designed to support patients at the start, so from the very beginning when a new medicine was started for their long-term condition. Initially, NMS was seen as smaller and more specific in comparison to MURs. But over time and through evidence, including research carried out by Professor Nick Barber, who you might have met if you have completed the CPPE training, NMS has been shown to not only just improve adherence, but patient outcomes, giving it a distinct identity and value all on its own. In fact, as we know, NMS has actually outlasted MURs, which were decommissioned in 2021. Which highlights how the service has grown from being in its shadow to becoming the cornerstone of pharmacy practice. So as you said, what's new? So October 2025, NMS expanded to include depression. This means that patients over the age of 18 who are newly prescribed certain antidepressants are now eligible. The consultation timings have also been clarified in that intervention should take place 7 to 14 days after recruitment, with follow-up happening 14 to 21 days later. It's also really important to note that subcontracting of the service is not permitted, and the service must be carried out by a pharmacist who's directly employed by the pharmacy owner. Training. So training isn't mandatory, but CPPE offers excellent modules and a gateway page on NMS. And one of the modules that they direct us to look at is consulting people with mental health problems. And we'll look at that specifically a little bit later on. But above all, the 2025 update recognises the vital role we pharmacists play in supporting patients with mental health conditions, particularly during the early stages of treatment. So why antidepressants? Why were they added to the NMS? Well, it was to do with the sheer scale of prescribing and challenges patients face when starting treatment. In 2024-25, nearly 8.9 million people in England received prescriptions for antidepressants. That's a huge proportion of the population, and about a third of those were newly prescribed. We know that adherence is a major issue, and you'll hear me talk about this quite a lot. Research shows that adherence to antidepressants drops from 95.5% at initiation to just 52% after a month. That's a dramatic fall, and it highlights how vulnerable these patients are in those early weeks. Antidepressants are the cornerstone of treatment for depression and anxiety, but they do come with their own unique challenges. The benefits are often delayed, taking 4 to 6 weeks to appear, and side effects are really common earlier on, but they do settle with time. And patients then might subsequently feel discouraged or stop their treatment before the benefits are actually felt. And this is why it's so important for us in our role and where we can make a really big difference. So through the NMS consultations, we can set realistic expectations with our patients about the delayed onset of benefit, can reassure them that early side effects often improve, and we can provide empathy and validation for those feelings, helping patients feel supported. Ultimately, we want to encourage adherence, but by focusing on patient empowerment, not just compliance. Adding antidepressants to NMS recognises our role in bridging the critical gap between starting treatment and experiencing improvement. So, as we said already, the service isn't just about improving outcomes, it's about reducing treatment failures and, crucially, supporting patients at their most vulnerable time. So, how is depression diagnosed? Well, in our role, it's important to remember that we're not involved in the diagnosis of depression. That responsibility lies with the GPs and mental health professionals. However, if we've got a basic understanding of how depression is diagnosed in the NHS, it helps us get a bit of context when we're supporting patients through the NMS. So diagnosis is based on a structured conversation about patients' symptoms, their lifestyle, and impact that depression is having on their daily life. Clinicians might use tools like the PHQ-9 questionnaire, which can be used to assess severity, and they will also introduce safeguarding questions around suicidal thoughts. And knowing this can help us appreciate the journey our patient has already been on before getting started on any treatment. And it allows us to respond with empathy, validate their concerns, and reinforce adherence. So while we don't actually diagnose in our NMS consultations, being aware of this process helps our NMS consultations be more compassionate, informed, and patient-centered. So now we know our lovely patient's been diagnosed. What does their patient-centered journey look like on our side? Before we dive into the detail of recruitment, let's take a step back and think again about what NMS is really trying to achieve. So it's not just about following a protocol, it's about creating a structured journey for our patients, which aims to support them at their most vulnerable point when they're starting the medicine. We know that early experiences with treatment can shape whether a patient decides to carry on with their treatment or stop. And that's why the NMS pathway is designed to give pharmacists 3 clear touch points. So 1, to welcome the patient in, 2, an early check-in or intervention stage, and 3, to follow up when they've had time to adjust. Each stage, recruitment, intervention, and follow-up, builds on the last, ensuring patients feel listened to, reassured, and supported. So that being the case, let's walk through the pathway step by step, starting with recruitment. So recruitment is where we identify those patients who have just started a new medicine for an eligible condition. We invite them to take part in the NMS, explaining the purpose of the service and record their verbal consent. So at this stage, it's about making patients feel supported right from the start, not just handing out the prescription. The intervention consultation, as we said, then happens 7 to 14 days later. And this is our opportunity to explore how the patient's getting on with their medicine. Might ask about side effects, check adherence, and discuss expectations again. And this is especially important with the medicines like antidepressants, because, as we said, the benefits can take time to appear. The focus is on reassurance, practical advice, and empowering patients to continue treatment safely. The follow-up consultation, that's 14 to 21 days later. And here we're really reviewing progress. So have side effects settled? Is the patient beginning to notice any benefits? Are there any ongoing concerns? And we can still reinforce adherence and provide further support or escalate safeguarding concerns if needed. But hopefully now our patient is stable, feels supported, and we can close the NMS cycle. So the effectiveness of NMS, as we've already said, doesn't just rely upon the structure of recruit, support, and review. It's really about how we communicate. So for one, using compassionate and supportive language helps patients feel safe and respected. Two, we need to use open questions to encourage our patients to share their experiences, which gives us a richer insight into their personal challenges. And our role is to empower patients, not in simply just to tell them to take the drugs. And shared decision-making means that they feel ownership of their treatment. If we acknowledge their concerns, this helps to validate their experiences and builds trust and empathy, which is especially important in mental health. And finally, it's really important that we demonstrate active listening. So reflect back, clarifying what we've been told, show genuine engagement. This is what makes patients feel heard and supported throughout the whole service. So what medicines are we specifically talking about? This slide highlights the antidepressants which are now included on the NMS service as outlined on the NHS Business Services website. The commonly used agents we've got are a big chunk of SSRIs. So we've got citalopram, escitalopram, fluoxetine, paroxetine, and sertraline, with sertraline probably being the most widely prescribed first-line option. And then we've got other agents. So we've got two other agents there. We've got duloxetine and mirtazapine, just slightly different mechanisms of action, but ultimately are there to treat patients with depression. So let's look at the big class first. So the big class being the SSRIs. So we've got citalopram, escitalopram, fluoxetine, paroxetine, and sertraline. And as most of us will remember, their mode of action is to do with increasing serotonin availability in the brain, which helps improve mood and reduce symptoms of depression. It's really important, this is the mantra of this evening's webinar, but the onset of benefit is delayed and it's usually 4 to 6 weeks. And it's really important that we let our patients know that that's the time scale before they may feel better. As this is a really difficult period, reassurance is absolutely key. Early side effects are also really common. So things like explaining to our patients that they might experience a bit of gastrointestinal upset, sleep disturbance, headaches, sexual dysfunction. The crucial counselling point on these is that they do settle with time and that not all patients experience the same side effects, but sometimes forewarned is forearmed. And that they should be encouraged as far as possible to persevere. And if they are struggling, welcome them back so we can talk to them again. Because as we know, adherence is vital. So stopping suddenly can cause withdrawal symptoms. And we want our patients to feel supported to continue their treatment and seek advice before making any changes, whether that's with us or we're referring them back to their prescriber. And finally, we really want to encourage patients to report any persistent or distressing side effects. This helps ensure that they feel listened to and supported and allows us to work with prescribers if adjustments are needed. Overall, our role is to provide early support, normalize the experience, and help patients feel confident about continuing their treatment. So let's look at sertraline in a little bit more detail. And again, there's tons of information. We've got BNF, SPC, lots of NHS resources. The NHS has got good web pages on each of these drugs that we're going to look at individually as well. But these are just some of the key points that you may want to build into your consultation. And again, we'll all have slightly different styles. Sertraline is an SSRI antidepressant, and it is commonly used first line. Again, mode of action is around increasing serotonin levels in the brain, which we know improves mood. It's usually taken once a day. It's not fussy, so it can be taken with or without food. And patients often start on a low dose that is gradually increased. And again, this might be helpful in terms of helping our patient understand their treatment expectations. As we said already, a really important counselling point is the delayed onset of benefit, which at this stage everyone hopefully remembers is 4 to 6 weeks before they may not feel any improvement in this timescale. Again, just covering over early side effects might be helpful so patients, again, don't quit on the treatment early. But things like headache or nausea or diarrhea, sleep disturbance or sexual dysfunction can be common. But again, reassuring them that they often settle within the first weeks. And again, adherence being really crucial, because stopping suddenly before seeking medical advice it can cause withdrawal symptoms. We should encourage our patients to be taking their dose at the same time each day. And if they, for example, do experience insomnia, perhaps mention that it would be better for them to take the medication in the morning, although it's important that whatever time of day they decide to take it at, they're consistent with doing that. So citalopram then. Citalopram is probably used a bit more second line, and we certainly still see a lot of prescriptions for citalopram. Again, it's taken once a day, and it's an SSRI. Side effects here, really similar in terms of nausea, dry mouth, sweating, sleepiness, and sexual dysfunction. Of particular note, though, with citalopram, and to look out for, there is a caution in cardiac patients because it can cause a QT prolongation. So just keep an eye on that if you're worried about patients maybe with a cardiac background, and don't be afraid to check that with clinicians. Again, in terms of the side effects, we just need to remind our patients that they often improve within the first couple of weeks, and support their adherence by validating their concerns and explaining why the gradual improvement is expected. Escitalopram, so an active enantiomer of citalopram, so same ingredients as citalopram, just different arrangements, so a sibling of citalopram. And actually you can position this one as generally better tolerated. Again, indicated for depression, taken once a day. Side effects include headaches, nausea, diarrhea, dry mouth, dizziness. Again, emphasize that there could be a delay in the onset of benefit, as improvement can be gradual, but encourage our patients to stick with it. And just encourage them as well to monitor for side effects and let us know. Fluoxetine. So fluoxetine, another well-known SSRI for depression, notable actually for its longer half-life. So it tends to cause fewer withdrawal symptoms in comparison to the short-acting SSRIs. Some patients find it makes them feel a bit energized or activated, and some patients then find a bit of insomnia, so difficulty sleeping or anxiety early on. If that's the case, then advising morning dosing can help reduce sleep disturbance. And again, you'll find lots more tips and things like that if you look at the NHS resources or the NHS webpage on it. This is just a very top level. Side effects, so again, back to the GI side effects, which is fairly common with the SSRIs, headache and sexual dysfunction. And again, reassurance here that these do often settle. Paroxetine's the last of the SSRIs that we're going to look at, and where fluoxetine has a longer half-life, Paroxetine's shorter half-life, but this does be mindful that compliance is really important then, because stopping or abrupt withdrawal can cause withdrawal symptoms. It does have a slightly more sedating profile in comparison to, say, fluoxetine or sertraline. So it can be helpful, and it might be a reason why a prescriber selects it in terms of a benefit to help patients if they're struggling with sleep. It does, again, also come with side effects, including sexual dysfunction and weight gain. And so, again, we just need to reassure our patients that these settle or often do settle. And again, really, really important because of the short half-life that they don't have interruption to taking this medication. So looking at the other two antidepressants that we've got on the list, so we've got serotonin noradrenaline reuptake inhibitor in duloxetine, and that works by increasing both serotonin and noradrenaline. They're often chosen actually when patients have coexisting conditions, so maybe anxiety and pain alongside depression. Key counselling points, again, it's not so friendly GI side effects, but things like nausea, also sweating, constipation, and raised blood pressure might be something just to look out for as well, with duloxetine. And again, in terms of withdrawal symptoms, really important that we talk to our patients about not stopping suddenly, and if they need to, they will need to be weaned off that slowly. Then we have mirtazapine, which is a noradrenergic and specific serotonergic antidepressant, and it acts slightly differently, but ultimately tries to boost both of these, both the serotonin and noradrenaline, to combat depression. Again, really helpful option in patients who perhaps are struggling with sleep, and also maybe poor appetite, as it can promote weight gain. And that's one of the side effects to let patients know about, as well as sedation, although it's often picked for that reason. And again, dry mouth. But generally tends to cause fewer of the sexual side effects in comparison to the SSRIs. So again, just be mindful of maybe that was a reason why it was selected. Okay, so we've got a bit of a case scenario to look at, and it would be great. I appreciate, we said at the start it might be difficult if people do or don't want to engage, but if you could, and you feel able to, maybe putting some comments in the chat box would be really helpful. We're going to look at a 28-year-old woman who's just been prescribed sertraline 50 milligrams once a day for depression. So it's a fairly typical patient experience that we're looking at here. She collected her prescription for sertraline a week ago. She's now on the phone or in person with us doing her NMS intervention consultation. So it's 7 to 10 days later. So far, she reports nausea and mild headaches. And she's telling us she's worried because she doesn't feel any better yet. And she's concerned that the medication's not working. She admits she's already missed 2 doses, saying that she wasn't sure if it was worth continuing, and she's anxious about the idea of being on tablets long term. Hopefully, at recruitment, we've already explained that the service is here to support her while she starts her new medicine, and that we're checking in over the next course of the next couple of weeks to see how she's getting on, checking if she's having any questions or queries, and make sure she feels confident about her treatment. Also, hopefully, we have reminded her, as we said numerous times already, that it may take several or a few weeks before the medicine becomes effective. Again, this hopefully has set the expectations early on in her journey, that the patient's not alone, and it frames NMS as a supportive journey rather than just one-off consultations. If we manage to introduce NMS in this way, we normalise the delayed onset of benefit. We encourage the patients to see the service as a safe space to share any concerns. Now we've got her at the intervention stage, what sort of open questions or supportive language could we use? So just click onto the next page. So if we just even have 30 seconds a minute, I'm not sure I will see the chat box, but if we just take a 30-second break and pop in what questions that you might ask this patient, thinking about the fact they're at the intervention stage. I'll keep a little eye on the time. I'll give it another moment.
No one in the chat room yet. Oh, here we
Hey, we
go.
got some.
Got one.
Thank you. What have we got?
Can you see that, Claire?
Yeah, I can. Yeah, thank you, Promise. The reassurance that medicine isn't addictive. Yeah, great. Yeah, yeah. Because again, it's all about managing our patients' expectations, and they may not necessarily be accessing the same resources that we are accessing, and so a lot of people now take advice from social media and things like that, and it's really important that we acknowledge that perhaps this is something they've seen and then maybe reframe it and say, okay, I can see you're worried about that, but this is the resources that I would use. So yeah, great, really brilliant. Um, Explaining it's going to take a few weeks this event. Thank you, Sadia. Yeah, definitely. That's something that's really key when we're talking about the antidepressants. That it is a case of perseverance and bearing with it. Thank you both for getting in. Oh, Harpreet, thank you. Supporter for the time it takes to get ease symptoms and director to support services. Brilliant. Thank you all. Um, Try and focus on what side effects are most troublesome. Yeah, definitely. Yes, because we obviously can't have super long consultations. So yeah, see which ones are the most troublesome. And as we'll talk about later, listening to what is the patient's concern and then trying to see if we can reframe it. And we've got some resources that we'll look at. Because sometimes it can be hard and we feel a bit helpless and we want them to feel better and we want them to take the medicine. So we've got some tools coming out later, which hopefully will be helpful in trying to even get around side effects. So thank you. Great. Okay, let me whiz away that chat box. Let's see if we can get some more. There we go. So at the intervention stage, as we said, so active listening is really, really important. So we need to listen to what the patient has come back and said to us. So if we're listening to the patient, it gives us space to talk, showing them that we've heard them. And it's really important, again, to reflect their words back so that they feel understood. So looking at some of the open questions that we could use, and again, everyone's got their own style. Everyone will manage their consultations in a different way, and use questions in different order, and it might be different depending on the different scenarios you're in. But I started with, "How have you been finding this medicine so far?" Because it's an open question. And it allows the patient to share negative and positive experiences. So, if, for example, they said, "I've been feeling sick," we can reflect back. "I hear that nausea has been difficult for you." So this is showing that we listened to what they said and validates their experience. We might also say, "What changes have you noticed since starting?" And this helps us explore the side effects, which everyone was talking about as well. And well, I've lost my train of thought completely. And again, what worries you about taking this medication? So, this question can uncover deeper concerns. So often about long-term use or stigma or side effects. So if they say, "I don't want to be on the medication forever," we can say things like, "I understand that the idea of long-term treatment feels worrying. Let's talk about how this medicine is usually reviewed over time." So again, setting their expectations about perhaps maybe the dose needs to be increased over time, depending on what they're on, and different things like that. So what we're really trying to do is balance empathy with information. So to help manage their expectations and open an opportunity back to the prescriber if we need to. In terms of supportive language, we might say it's really common for people to have side effects like nausea or headaches in the first few weeks, and this takes a bit of time to settle. Most people find that they settle. So again, normalizing the experience, but the active listening and the art of active listening means that we're not just stopping at sort of reassuring them, we're reflecting back. So you mentioned nausea. How's that affecting your day? So we're not dismissing the concern and saying, "Oh, but it will go away." We're trying to look and see about the impact it's having on that patient and opening the door potentially to solutions. Whether that's the timing of the dose, if it's making them feel particularly sleepy and move it to the evening time, or similarly, if they're feeling a bit activated on fluoxetine and we move it to morning. We also might say things like, I understand it feels frustrating not to notice the improvement yet. And as we know, it takes 4 to 6 weeks before you feel the benefit. Again, blending the empathy with education. Um, and reflecting back, so maybe listening to that, oh, it hasn't made a difference yet. So saying, I'm hearing you feel a bit discouraged because you haven't noticed a change yet, and that's understandable. And then we can add in some supportive information about the delayed onset. And also we look at a bit later about some other sort of resources that we can use or direct our patients to, supported by the NHS in these early days as well, while they're waiting for the benefits to kick in. The golden thread, as always, is active listening. So asking open questions, acknowledging what the patient says, reflecting back, and adding the supportive information. This approach empowers patients, validates their concerns, and builds trust. So it's not just about giving patients facts, it's about making patients feel heard and supported while they navigate the early days of treatment. So about follow-up. So again, just a quick sort of 20-second. Anybody got anything that they would say at follow-up that they could use to maybe reinforce adherence, or what would you encourage her? What would you say to encourage her to keep going? Only do like 20 seconds here. So some phrases we might want to put as part of our supportive communication style. Oh, thank you, Chowdhury. So more missed days means longer to establish steady state. They're longer to see benefit. Yeah, yeah, definitely. So a bit of education in there. I think really importantly, it's how we deliver that message. So absolutely spot on, and it's how we then frame it in a communication style that's empathetic and compassionate, but also gets the message across that as you say, that the longer that we miss doses or the more missed doses, then the kind of further away or in the distance the benefit lies. So some phrases in terms of supportive communication style. So I know it's been difficult, but taking the medicine every day gives it the best chance to work, which is essentially what you were saying. Or if you ever feel like stopping, please do talk to us or talk to your prescriber, as stopping suddenly really can cause those withdrawal symptoms and make you feel not very well. Or if side effects don't settle or become distressing, let us know straight away and we'll look at resources to help. In terms of either side effects or so severe side effects or any areas that we need to escalate, so for example, severe distress or self-harm or suicidal thoughts, that would be a clear point for escalation back to the prescriber. And we'll look now. Thank you for everyone who engaged in the case study. We'll look now at our safeguarding responsibilities. So on the topic of escalation, safeguarding obviously remains central to our role as pharmacists. And when we talk to patients with depression, we must remember that these conversations might uncover risks to safety or well-being. If you ever have concerns about patient safety, whether that's a risk of self-harm or suicide or vulnerability due to their circumstances, you must escalate appropriately according to your local safeguarding protocols. It's not an option. Safeguarding is a professional duty. It protects our patients, but it also protects the pharmacy team. So keeping the local referral pathways visible is one way to do that and accessible in the pharmacy. And that might be a laminated sheet in the consultation room or a quick digital link on your desktop. Having these pathways and what to do with them at your fingertips means that you can act quickly and confidently if concerns arise. Our local LPC website is a good place to check for updated safeguarding contacts and referral guidance. And I've just popped a little picture there of our website, and it's got all the latest up-to-date safeguarding links across the patch, so across Bob. And again, tabbing that on your consultation computer might be helpful, and just getting familiar with which links would apply to you as well. So again, a really quick 2 second chat box. How many of you have already completed the suicide awareness training? Just out of interest, has anybody done this already? No. Okay. So it's called the Zero Suicide Alliance training. It's recommended via the NMS Gateway page on CPPE. It's a free online course for professionals and the public, and it helps to recognize warning symptoms and start supportive conversations with patients who might be experiencing depression. Some of us might actually recognise that. I remember doing it the first time round for PQS, so the pharmacy quality scheme in 2020-21. It's an NHS endorsed resource. It's developed with partners in the Merseycare NHS Foundation Trust and the Samaritans. It's been recently updated in 2024 to reflect current best practice. So anybody who might have done it as I did initially, it is worth redoing. It's a short interactive course. It takes about 30 minutes. There's videos to watch as well. It's quite engaging. Designed for anyone who's over the age of 16. And it helps recognize risk factors and warning signs of suicide, and also how to start having a supportive conversation with someone who you might recognize as struggling. There are some real life scenarios, and you get to hear from people with lived experience. And for me, it really put things in context in terms of having these types of conversations. And it also helps gain a bit of confidence towards signposting to appropriate support services. Get a certificate, which hopefully you can see mine there. But more importantly than that, obviously, it does help with practical skills and makes a difference in terms of safeguarding, gives us some confidence in terms of what we're doing with safeguarding. So again, this is literally a screenshot from the Zero Suicide Alliance training. But hopefully, as you've heard running through the webinar, the absolute key is communication. So when we're discussing mental health, language more than anything matters. So it's really tricky, but it's important to avoid dismissive phrases. So saying things like, don't worry, or you'll be fine. I know I'm really guilty of always wanting to make things better for people. And so, oh, you'll be fine. That in these situations isn't that helpful. So it's really important that we try and take a step back, demonstrate our active listening, acknowledge our patient's concerns, and show that empathy. So saying things like, I can hear you're finding things difficult. Let's talk about what support might help. And this is the sort of these sorts of scenarios are modelled in the Zero Suicide Alliance training. And this approach, in doing this, it validates the patient's experience and it opens the door to safeguarding conversations without stigma. The training also highlights that you might actually slip up, and that's okay too. The main aim is to provide a listening ear and potentially support someone with suicidal thoughts. And it really does encourage you to not avoid the conversation because you're concerned about saying the wrong thing. The conversation you have might actually save someone's life. And I spoke to one of the clinicians at work about this, who reminded me, and as we said, in terms of diagnosing depression, GPs and mental health professionals have already had these conversations with our patients. So they're used to hearing this language. They're used to being asked if they have had suicidal thoughts, if they are at risk of self-harm. So by being direct, you give that person an opportunity to share their feelings and potentially open up. I had exactly this scenario in an OSCE where I encountered a very troubled patient and she was very anxious. Obviously, this was an OSCE setting. And I felt, again, as part of my personality, I knew I needed to ask the direct questions, but I rushed the two into one. So I said, are you having suicidal thoughts or thoughts of self-harm or suicide? And she replied, not self-harm. And I took that to mean not self-harm and suicide. But actually, as we explored the OSCE further, she did have suicidal thoughts. So that's where it's really, really important that we actively listen to what we're being told. Because safeguarding ultimately is about being prepared, being compassionate, and knowing when to act. So when we combine the NHS protocols with NHS approved resources, we can help the patients get the right help, the right support at the right time. Remember, safeguarding is protecting our patients, but it's also protecting us as professionals. So having these clear pathways and the training all behind us makes these conversations achievable, even under current workload pressures. Speaking of workload pressures, we know, or I know, that adding another service can feel daunting, but really, NMS consultations should be completely integrated into our workflow. Pharmacists don't need to carry the burden of NMS all on their own. The wider team are, as always, play a huge role, a vital role. So our technicians and dispensers can identify the eligible patients and spot adherence issues potentially early. Counter staff, wonderful counter staff, are often the first to hear of patients' concerns. So again, making sure they're trained to be able to listen and signpost, and even if that's just escalating to you in a sort of neutral, non-judgmental way, that's ideal. That's what we want. What we want our counter staff to be able to do, and that's their signposting. And then the tricky, deeper safeguarding conversations, that's for us to have. And locums, making sure that we have clear protocols and maybe scripts or certain language that we use to ensure patients get consistent support. And we can do that by using some of the checklists that are available. So Community Pharmacy England have got some checklists and FAQs to be able to streamline how we approach it. And again, remember to collaborate with our GPs, mental health colleagues, nurses. That's really, really helpful, especially when escalation is needed. But also, they will appreciate sometimes the insights from NMS consultations, as it can strengthen the patient's care. So when discussing the NMS service with primary care, and I've had this recently at PLT session, when I've let our clinicians know that community pharmacy is now offering this, but frame NMS as an investment. So highlight that, yeah, it's supporting adherence, which is really, really important, but ultimately is reducing long-term surgery workload by preventing treatment failures and repeat visits, GP visits. And GPs and practice managers will love to hear that. So really do, if you are engaging or letting your general practice know that you're offering this service, do underline the benefits of the service widely, NMS widely, not just necessarily linked to antidepressants. So team support is absolutely vital. So delegate tasks where you can and share that responsibility. In terms of training and professional development and building our confidence about consulting with patients about mental health, we've got training opportunities nationally and locally, and they're designed to be practical, accessible, and supportive. As usual, CPPE, as we said, have the specific module on consulting people with mental health problems as part of the NMS Gateway page. It takes about 2 hours. It's quite a practical module, but there isn't any assessment afterwards, so you can just work through it at your own time. Community Pharmacy England checklist and FAQs that we talked about, and they can provide practical tools and help break down the NMS process into clear steps and highlight maybe common patient questions. And again, if you use those resources, then you get consistency in terms of service delivery across the team, which can be helpful if you've got locums or new staff. Again, ourselves, so this evening's webinar will be available on our website as part of the Thames Valley Academy. And also you might see other trusted NHS training sessions available. Take advantage of those to try and build your confidence. And don't underestimate the power of reflective practice, because as we said, some consultations will go well and some don't go so well. So take a moment for both good and bad consultations to look at what went well and maybe what could be improved next time. Thankfully, we've spent a lot of time highlighting safeguarding and risk and all of the things that we might need to redirect our patients, but not every patient we see in NMS will need escalation back to the prescriber, which is reassuring. But some will benefit from being signposted to wider support services. And it's really important that, as we said before, patients, if they do look at resources outside of maybe the NHS's remit, that we are able to maybe redirect them into trusted resources that we would use. And that ensures credibility and safety. And also, it lets the patients know that we're using evidence-based data. So the big one here is NMS Talking Therapies, which is a national programme and it's known to all of us, providing psychological support across England. Patients are able to self-refer or be referred by their GP, although they're usually encouraged to self-refer. And these services include things like cognitive behavioural therapy, CBT, counselling, or guided self-help. For patients who have ongoing anxiety, low mood, or difficulty coping, signposting to talking therapies is sort of an extra layer of support alongside their medication. And we can phrase it like NHS talking therapies is available locally and talking about the practical support they give in terms of mood and anxiety. And maybe, say to the patient, did you want me to show you, have it on your desktop to be able to direct patients to it? And also, a clinician at work had mentioned that if someone broke their ankle, you give them painkillers, so paracetamol, ibuprofen to help with that. And that's sort of like what our antidepressants are doing. But actually, it's the physio that gets the joint working properly again. And so I've always kind of kept that analogy in my mind about, why we might offer these sort of additional resources. They're kind of like the physio for the mind, so to overall help the patient get better. We've also got Mind. So Mind's a really well-known mental health charity. It's got helplines, peer support, and practical advice. And they provide information on conditions or treatment options and coping strategies, which patients might feel helps them feel a bit less isolated. Or patients that maybe just, don't want to necessarily always engage with us or GPs, they might find it helpful to reach out to another setting. So that's where you might think about Mind. Rethink Mental Illness it focuses on severe mental illness, but also offers more sort of practical advice. So support on things like housing or employment and benefits and areas that can be major stressors for patients. And again, have this maybe in the back of your mind if you've got a patient that's telling you, that their condition's not getting better and they're worried about their job or they're worried about benefits and things like that. This might be an appropriate place to direct those patients to. Because Rethink can be a bit of a lifeline for them. And by doing the signposting, we're empowering our patients to look at wider support networks, so beyond us in pharmacy or in general practice. It shows that we're listening and we're responding to the concerns holistically, but not just focusing on their medicine, which builds trust, it reinforces that shared decision-making process, and it helps patients feel supported in multiple aspects of their recovery. Okay, so we're getting to the end of the self-help bits. And I've got a link here just on this page. This is again to the NHS page. And this looks at, rather than the talking therapies or the charities in mind and Rethink Mental Illness, these are NHS approved evidence-based tools that patients can access themselves. And again, it might be helpful in those overwhelming situations if, like me, you just desperately want to be able to help or let the patient feel they've been given something. So these resources include stress busters, breathing exercises, the 5 steps to mental well-being, exercise guidance for depression, and audio guides for relaxation and sleep. As pharmacists, we can use them to complement NHS consultations. So they're not a replacement for treatment, but they help our patients maybe with some practical strategies that they can try alongside their medicines. Thinking about maybe how we'd weave them into our consultations, though, we could look at, again, actively listening. If the patient mentions that they're feeling stressed or anxious or struggling to sleep, we can acknowledge their concerns. So we can say things like, I hear that stress has been difficult for you. The NHS has got some simple breathing exercises or stress tips that you might find helpful. Or we know that patients can feel powerless while they're waiting, and again, that delayed onset of benefit for antidepressants to take effect. We might be able to offer them this in saying that the medicines take a couple of weeks to work, but some people find that small steps like gentle exercise or relaxation techniques can help in the meantime. So in a way, this frames the tools to complement the treatment. We could also mention NHS audio guides that patients can listen to at home. They're short and they're practical, and patients find that they help with worry or sleep. Or we can also use maybe suggesting these tools as a hook for our sort of follow-up NMS, maybe by saying, did you get a chance to look at the NHS wellbeing tools? How did you find them? This shows continuity, it reinforces our active listening, and it builds trust. And by integrating these services, resources rather, into our NMS conversations, we're demonstrating compassion, we're acknowledging the patient's concerns, and we're empowering them with practical tools, which again, ultimately is hopefully supporting adherence and helping the patients feel supported, particularly while they're waiting for their medicine to take effect. And again, that can be the really tricky time for patients. So, as we finish, so just to recap, the NMS service has expanded to include depression and antidepressants, which is a significant step forward, representing the vital role pharmacy plays in supporting mental health. At the core of the service, as we said throughout, communication and shared decision making is very important. Every conversation is a chance to listen and empower and make patients feel confident in their treatment journey. We absolutely must keep safeguarding and signposting in the forefront of our mind. Thankfully, not every patient will need escalation, but many will benefit from being guided towards trusted NHS resources and support networks. And this ensures our care extends beyond the pharmacy counter. Importantly, try and think about the workload as manageable by reframing our own mindset. So, with the right tools, clear processes, and teamwork across pharmacy, NMS can be delivered smoothly and consistently without unnecessary pressure. And don't forget, we're not alone. We've got excellent training resources. We've got CPPE, we've got the LPC here, and other NHS programmes. They're there to build our confidence, strengthen our skills, and support us in delivering the best care. So I'm really hopeful after this evening session, you're keen to embrace this opportunity. By combining our clinical knowledge with compassion, teamwork, and continuous learning, we can make a real difference to patients living with depression. Thank you for the care that you give every day and the commitment you bring to supporting your patients. So thanks everyone for listening. Again, I can see maybe there's something in the chat which I'll get a quick look at. If you don't mind sharing, it would be lovely to hear if you've learned anything new today, if there's anything that you might do differently tomorrow, any ideas or phrases that you found helpful, or how might this evening's webinar influence the way that you approach patient-centered care, specifically about NMS. We'll look at these really quickly.
Thank you very much, because that was me actually. I was just putting a link to the Academy resources.
Brilliant.
That was really, really good. Thank you very, very much indeed.
No problem.
Are there any questions from the room? We've also got Kevin here, who's the contractor support officer. He's more than happy to visit your pharmacy and take a look at any processes or answer any questions you've got with the relationship with your GP or your trust or whatever. And let's see what we can do to help you take that forward. Anything from anyone? No? Well, I do thank you all for giving up your time this evening. And thank you, Claire, once again, for putting together a really good, solid presentation for us. I will put this on our YouTube channel, which I posted in the chat in the next couple of days. And we look forward to welcoming you next year, when we'll hopefully have a new series of webinars and face-to-face events to help you create a better environment for your staff and your patients in your pharmacy. So thank you for everything that you do, and hopefully you do get some downtime during the festive break. You deserve it, because you all work so hard all through the year, and we really value everything that you do. Thank you very much. I will now stop recording.